I'm going to go a little bit into anterior hip replacement and then other ways that things have changed over the last 5 to 10 years or so to improve the recovery process, get people home faster, get them back to their normal activities a little bit quicker. So just to briefly touch on some of the basics, hip arthritis or any arthritis really is really just describing a process that involves loss of articular cartilage. So any joint that you look at, the bones are actually lined with this soft, kind of smooth surface that's a protective layer. And when that thins, that's what arthritis is. And there are multiple different reasons that you can get arthritis. The most common by far is just osteoarthritis, which is just wear and tear of the joint. But you can also have inflammatory arthritis, which is essentially the body's own immune system attacking the cartilage. You can have had trauma to the joint, which results in eventually thinning of this cartilage. But really, regardless of the reason for that articular cartilage thinning, it all results in a similar process, which is pain in the joint, stiffness, limited range of motion, and eventually a decrease in function. So going into the treatments for hip arthritis, we always start with the non-operative treatments first. Really the mainstay of this treatment are anti-inflammatory medications, and those involve both oral and topical applications of the anti-inflammatories. Activity modification is often very helpful, for patients who are doing high impact activities. We often recommend that you stay away from things like running, jogging, activities that involve jumping. Physical therapy can often be quite helpful as well. I think a lot of patients find that their range of motion can improve by strengthening the muscles around the hip. They're able to do things that they like to do for longer, have better endurance. Certainly injections can be helpful. There are probably 4 injections right now that people are typically doing for arthritis of the hip. Really only one is recommended by the American Academy of Orthopedic Surgery, and that's cortisone. Weight loss can certainly be very effective as well. And then assistive devices for people who have progressed to the point where they're really having difficulty getting around or just doing simple daily activities. I think using a cane or a walker can be quite helpful. When patients have tried all of these non-surgical treatments and they've reached a point where they feel like they're having trouble with even simple daily activities, getting up and down stairs, walking around town, walking just a couple blocks, certainly surgical treatment becomes an effective option for them. And in 2018 right now, there's really only 2 treatment options, surgical treatment options for hip arthritis. And that involves total hip replacement and then hip resurfacing. I would say if you look at the trends over time of hip resurfacing, only about 0.5% of hip arthritis in 2018 is treated with a hip resurfacing. And there were multiple issues with that type of procedure. So I think by and large, if you ask many orthopedic surgeons who treat hip arthritis, they'll tell you that hip resurfacing is kind of a dying treatment plan. So we're going to focus a bit more on total hip replacement surgery. So, who is a candidate for total hip replacement? Certainly, when patients come into the office, we want to listen to their history. How long have they been having symptoms? What treatments have they tried? We want to do an exam. Do they have stiffness in the joint? Is it painful when they move the joint around? Certainly, we'll look at their imaging, make sure that they have, a significant amount of arthritis in that joint. We want to make sure that they've tried and failed, most of the conservative treatment options, and that they've reached a point where they really have some real functional limitations like we discussed. So when you get to that point, you're a candidate for a hip replacement procedure, but really ultimately the timing of that operation is kind of a personal decision. Everybody's a little bit different in terms of how much pain they can tolerate, in terms of how much, functional limitations they can tolerate. And when you feel like, you've really given this hip a good shot, you've tried most of the conservative treatment options and you just can't live with this thing anymore, I think it's very reasonable to think about hip replacement surgery. And, the good news with that is, the vast majority of patients who have a hip replacement, we're talking, over 95% are very satisfied with their outcome. So it is a very effective treatment option for patients who do ultimately decide to have the operation. So I'm going to talk a little bit, more in detail about rapid recovery, the changes that we've made over the last 5 to 10 years or so to get patients home quicker and get them back to their normal activities faster. This is kind of a stepwise process, and there are different strategies that we employ kind of at each stage of the surgical process. So before the surgery, of course, we want to work on patient education. So I think the better the patient is educated, the more they understand going into this surgery, the easier the operation is going to be, the easier the recovery is going to be. So typically patients will go to a class or they'll discuss with one of our case managers, what to expect when they get home, what things to put in place before they have the surgery so it's easier to recover. There are certainly a number of studies showing that prehabilitation, where patients are going to physical therapy prior to the surgery, is helpful. I think certainly the better shape you're in going into the operation, typically the easier the recovery. I'm going to talk a little bit more in detail about the less invasive surgical approaches that we're doing, specifically the anterior approach. You heard Dr. Delos talk a fair amount about the new anesthetic strategies that we're using, as well as the multimodal pain control, which essentially is small doses of lots of different medications, and they all kind of work synergistically together to minimize pain. And then after the surgery, patients are getting into physical therapy faster, they're walking quicker, they're getting home faster, and I think all of this just kind of reinforces the rapid recovery. So talking a little bit more about approaches for total hip replacement, I'm going to speak specifically on the anterior approach, but I think it's important to remember that there are lots of different approaches to perform a total hip replacement. And it's important to remember that really all of them result in the same thing. And regardless of the approach you have, the vast majority of patients, as I mentioned, have a very good outcome. But looking a little bit more closely at the anterior approach, it's actually not a new approach for hip replacement. It was first used back in the 1940s. But it's really the only intermuscular approach, meaning when we're getting down to the hip, we truly don't cut through any muscles or tendons. And if you look at this brief video, what you see is that you make a small incision over the fascia, which is kind of a connective tissue envelope of the muscle, over a specific muscle called the tensor fasciae lata. You kind of bluntly dissect or use your fingers to move that muscle out of the way. And then after that, you're placing a retractor directly over the capsule of the hip. So there is another muscle that sits over the hip joint, which you'll see kind of at the top of that incision, which is called the rectus femoris. But once you've moved the rectus femoris muscle out of the way and the tensor fasciae lata muscle out of the way, you're essentially down to the hip joint. There's really, as you can see, no muscles or tendons that you have to cut to get down to that hip joint. So really what you're looking at there is the hip capsule directly overlying the hip. And this is compared to the other approaches where you do actually have to cut through a fair amount of muscle and tendon to get down to the hip capsule. Another benefit of the anterior approach is the patients are typically in a supine position, meaning they're laying on their back during the operation. And what that does is it facilitates the use of fluoroscopy. And what fluoroscopy is essentially a live x-ray that we use. And what that does is it kind of removes the outliers, after the surgery. So before the patient ever leaves the operating room, we can confirm that all of their implants are in the position that we want them to be. We can check the patient's leg lengths and make sure really that we've done the operation that we've planned before the procedure and there aren't any outliers after the operation. We also do typically use this fracture table, which is a special type of table that just facilitates this approach. It helps us put the leg in different positions that allows us to do this minimally invasive procedure and get good access to the bones in the hip joint. So there have been a lot of studies recently over the last 5 years or so looking at what are the specific benefits of the anterior approach. And certainly you'll have your proponents of the approach and the opponents of the approach, just like any other change that we have within medicine. But the more and more studies that come out, the more they're reinforcing that these are the potential benefits of the anterior approach. So as we discussed, certainly it's muscle and tendon sparing, meaning we're not cutting through any of the muscles. You don't have any precautions or restrictions after the surgery. So typically with the other approaches, there are specific movements or positions with the leg that you can't get into for about 6 weeks after the operation. With the anterior approach, you can move the leg however you want immediately after the surgery. And I think this just makes it a bit easier, a bit more relaxing for the patients as they're starting their recovery and not worrying about putting the leg in positions that they shouldn't be. As we discussed with the fluoroscopy, I think there's no outliers after the surgery. We really kind of know where we're putting those implants by the time we leave the operating room. A fair number of studies have shown that because you're not cutting any muscles or tendons, most likely, there's an earlier return to function. So this is primarily within the first couple months after the surgery. Certainly studies have shown that there's less pain, patients are getting out of the hospital faster, quicker return to normal gait mechanics, and then one of the main benefits that I think compared to something like the posterior approach is there's likely a lower dislocation rate, which is one of the main complications with the hip replacement. And because of all these benefits, if you look at surgeon surveys over the last 5 years or so, there's no question that the anterior approach is becoming more popular. So, in 2011, for example, maybe 8% of surgeons said they did some element of their total hip patients with the anterior approach. Now, it's probably up to about 50% or so. So I think surgeons are also seeing the significant benefits from this type of procedure. And because of that, it's really gained a lot of traction over the last 5 or 10 years. Not to go into the scientific studies too closely, but this is one of the more convincing studies that's come out over the last couple of years. It was a randomized control trial, which is kind of the highest level of evidence that we have in medicine. And it was an interesting methodology where the patients would come into the office, and regardless of the surgeon that they initially saw, they would be randomized to either the anterior approach or the posterior approach. And they did about 50 cases in each of those different approaches. And there was no difference between the groups in terms of their age, their BMI, which is their body weight, their medical comorbidities, or their preoperative function. And really what they found is that the patients with the anterior approach had faster recovery, they had lower pain scores, they were using less opioids or stronger pain medications. Their patient-reported outcomes or questionnaires were better at 2 months, but by about a year they had equalized. And there were really no differences in complications. So what the authors were showing was that it was a safe approach and that the patients tended to recover more quickly after the operation. So we like to say in orthopedics, there's really no free lunch. So there are certainly some risks that come with the anterior approach. And I think because we're using fluoroscopy and we're spending time to get a good evaluation of the position of the components we're putting in, we're making leg length adjustments during the operation, I think that adds time to the operation. And so it's probably a bit slower than the other approaches. There is a nerve that travels very close to the incision called the lateral femorocutaneous nerve. And in maybe a third of patients, they'll get a little bit of numbness on the skin next to where the incision is. But in the vast majority, probably about 80% or so, that numbness does resolve within about a year. Some studies have shown putting that femoral implant in is probably the toughest part of the anterior approach. And so there might be a slightly higher risk of fracture to the bone when you're doing that. And then if you're going to have a revision procedure where you actually unfortunately need to come back to have some type of operation done to fix a problem with the hip replacement, very few surgeons these days are using the anterior approach for a revision. So typically you would have another incision to fix a problem with the hip replacement. And so a lot of patients, who come into the office ask, well, who should, have an anterior hip replacement? Who's a candidate for this? And I think by and large, the vast majority of patients are candidates for anterior hip replacement. I'd say probably 90% of the hip replacements I'm doing right now are through the anterior approach because I do think the patients are getting quite a significant benefit from it. But patients who have had prior surgery on the hip, they have hardware in there that we have to take out. It's probably not the best choice. Patients who have significant deformity of the hip have considerable dysplasia, which is differences in the bone compared to normal anatomy, probably not the best choice. And then for patients who have a body habitus where their belly is probably overhanging the incision, I think the wound healing can be a bit more tenuous, and so it's probably not the best choice of procedures either. Not to go into this in too much detail because Dr. Delos covered this very well just prior to me, but another component of this rapid recovery is multimodal anesthesia, where we're using multiple different medications, typically 4 to 6 pain medications at lower doses, and I think they all come together to work synergistically. Regional anesthesia is, the nerve blocks that Dr. Delos spoke about. And then during the operation, whether it's a knee replacement or hip replacement, the surgeon's typically doing hundreds of small injections of a anesthetic that can last for up to 3 days. And I think when you combine all these things together, people are really, having not as much pain after the surgery. They're getting up and walking faster and getting home quicker. And then in terms of the wound closure, I typically use a skin glue, so there's no staples or sutures. It's waterproof. You can shower right when you get home. We're putting a waterproof dressing on there. So patients really don't have to worry too much about their incisional care or anything really at all when they get home. And I think when you put all these things together, it lends the ability to start to do extremely rapid recovery where people are actually coming in, having their surgery and going home the same day of the operation. So, this is for specific patients. It's not for everybody. For motivated patients, for healthy patients who really just don't want to spend too much time in the hospital, I think this is becoming an option for them. So just to review, I think it's important to remember that overall, total hip replacement, regardless of the approach that you have, is a very, very successful operation and is very effective at getting rid of that arthritic pain. For some patients, the anterior approach is associated with earlier return to function, less pain, less opioid usage, lower risk of dislocation, and so I think this does certainly speed up recovery. And the vast majority of these patients these days after a hip replacement are able to go home within just a couple days. They really have no restrictions after the surgery. You can move the leg however you like. You can shower right away. They're taking opioid analgesia, for just a week or two. Some actually aren't even using any opioid analgesia after these anterior hip replacements at all, and getting back to most of your activities within, just a month or two. So I think we've made a lot of changes, and it's really improved the recovery process for patients. So thank you very much for your time.